but we'll go ahead and get started. I know it is a little bit past 10:15. I see Magali's here. So Magali, I'll go ahead and hand it off to you, and you're welcome to get started here. Yes, we can hear you now.
Okay, thank you. So again, I was just saying good morning, and it's a pleasure for me to have the opportunity to be here with you today to talk about what I conceive a very important topic, which is really looking at comprehensive medication management and really making sure that as we continue to work in a model, we continue to work in the Maryland Primary Care Program, that we all come from the same perspective about what do we mean when we talk about comprehensive medication management, and that we all develop a standard way for us to provide these services to our patients. So in that way, there's consistency where individuals do receive their care. I am an Associate Dean for Clinical Services and Practice Transformation at the University of Maryland School of Pharmacy. I'm also the Executive Director of our Center for Innovative Pharmacy Solutions. And I have really the privilege of working with both with the CTOs, with the care transformation organizations, but also with some of the primary care practices in the state, really facilitating and providing pharmacists that are working with these practices, providing comprehensive medication management services. So with that, let's get to, again, the session today. So I have no conflict of interest with any of the content that I'm going to be providing to you today. And what we're going to attempt to do in our time together is the following. It's really get to talk about what are the principles of comprehensive medication management and really get into what are the steps, how do we do it? Translate what are the importance of medication reconciliation, medication tracking, and develop strategies that really will help us not only deliver these services, but really provide the important medication education and information that our patients will need. To be able to accomplish that, these are some of the way that I had divided our time together. So what we're going to be doing is really defining the term, because one of the things that we're going to talk a little bit more later is that one of the steps that we have taken with the Maryland Primary Care Program this year is to really be very clear about what do we mean, right? What is the definition? What are the principles? And when we say that a practice is providing these services to the patient, that we all know what are the level of services they received if a practice indicates that they're providing comprehensive medication management services. So I think that defining it, talking about the steps is going to be really important, and we're going to do that. I also wanted to spend some time really highlighting for you what are the differences between medication reconciliation and comprehensive medication management, because sometimes we tend to get confused and define CMM as a MedRec or vice versa. And so I wanted to really highlight when we talk about comprehensive medication management, what do we say? And when we talk about medication reconciliation, what is it that we're talking about and what are those components? Then talk a little bit about how do we implement this in our practices? How do we decide which are the patients that get priority? How do we measure the outcome of those services? And how do we measure that we actually have been effective in doing that? And then I wanted to do a case just to highlight at a very high level some of the principles we're going to be talking about, and just gives you more of a practical, hands-on, how to approach some of the patients that we have in our practice. And I'm going to leave some time for you to ask me questions. So let's start by definition. So we did talk about that. And again, I wanted to highlight, this is the definition that we have adopted as part of the Maryland Primary Care Program in the state. And the definition of comprehensive medication management really indicates that it's a standard of care. And what I mean by that is, again, that is the way that we all agree that we're going to provide this care, that there is a process that we're going to follow. And the principle here is that these service or this comprehensive medication management approach, what we're assuring is that each of the patient's medications, and look what's in parentheses, not just the prescription medications, but any medication that that patient is taking, could be over-the-counter products, it could be, again, alternative therapies that they're using, or traditional, or vitamins, nutritional supplement, anything that the patient is using, that we ensure that that is assessed, that we assess individually each one of those medications, each one of those things that the patients are using, to assure, number one, that is appropriate for the patient, that there's really a clear indication for that particular medication or drug, to make sure that it's effective and that is actually indicated for the medical condition that the patient has, and then making sure that it's safe in the context of the patient's comorbidities, in the context of the other medications that those patients are taking, to assure that they are not drug and drug interactions that are occurring between those medications, and that the patient is able to obtain the medicines, but is also willing to take it as intended. And so again, it is really a more deeper and comprehensive analysis of everything that that patient is taking, to assure that, again, follows those principles that we're talking about, that follows the principle that is appropriate, that right? Not only for the indication, but appropriate for that particular patient under this particular circumstances, under these comorbidities. Particularly, one of the things we're going to talk about later, but that is critical, is what about the renal function of that patient? What about the liver function of that patient? Is that a medication that is dosed appropriately, or should be actually used in patients with those conditions? So again, this is the principle that we're going to follow, and the definition that we are adopting, that again is the standard of care, that is this assessment of each of the medications that the patient are using, to assure these steps and identify what we call drug-related problems, for us to identify what are those things that are happening in that drug therapy and how we're going to address that to resolve those problems. So to do that, and this you have it in your resources, so don't worry about the fact that you may not be able to read it. I just wanted to call attention that there's something that I called the 10 steps to achieve comprehensive medication management. And those 10 steps, again, are part of your resources, but it's really starting with identifying what are the patients that really may need these services. But I will attest to you that I personally, and this is my personal belief, is that every patient in our practices should have comprehensive medication management assessment or services, even if it is once a year. Even if once a year we look at all the meds the patient are taking, assessing that. But there are some patients that we're going to have to prioritize. And I understand that in many of our practices, we don't have the time, the resources to do this every time that we see the patient, but making sure that in certain circumstances, there are patients that we prioritize, patients that we know that those are the patients that need the services, or that there has been a change in the patient's conditions. For example, a patient that has been hospitalized, a transition of care. Those are critical moments for us to really do comprehensive medication management. Then the steps continue to really identifying what are the meds they're doing, looking for the appropriateness, looking for any of the problems, identifying the patient's ability to get them, making sure that we develop the plan, that we document and communicate it, and that we come back, because this is a continuous process. This is not something that we do one time and all done, but it's really any time that a change occurs, any time that there's a need for us to reevaluate drug therapy, we're going to start all over again. So again, the thing here is you have these, and I encourage you to really take a look at these steps. So when we talk about these kind of services, and when we talk about what is the context of comprehensive medication management and what are the goals, why should it be part of our model? We know that the goal ultimately is that we optimize medication use, that we optimize the way people take it for two purposes. One is to improve the medical condition or the reason why we're giving the med, but also to minimize and as much as we can prevent adverse drug events as a consequence of the medication we're giving the patient. So as such, we also know that when we provide these services, when we optimize medication use, we not only decrease medication costs, because one of the things that we find consistently when we do these services is medications that the patients are actually refilling and not taking. We also know that they may be less costly alternatives that have never been explored, all right? That may be as good and it may be even better than some other medications that the patient are taking that are more expensive. So really decrease medication costs, particularly we focus a lot in looking at copays and really helping our patients be able to afford the medications. Improve clinical outcomes, because if we optimize medication use, we know that that translates into control of the disease and as such, improvement in some of the clinical outcomes we're looking for. Decrease unnecessarily cost. And for some patients is less sick days, better quality of life. We also know that we have very, very good data that patients that receive these services do have less hospitalization, less ER visits. And by such improving the adherence, improving the patient's education and the patient's knowledge of how to take the medications, when to seek care, and when, again, they need to report things that are happening with the therapy. So again, we know that if we provide these services, if we do it consistently and we do it in a systematic manner, that again, we're going to reduce not only the amount of medicines the patient taking, the cost, but we're going to improve clinical outcomes. So as we're looking to comprehensive medication management in the context of case management, as we know in our model for Maryland primary care, these are services that are encompassing of a case management and case management principles. So as we integrate medication care and medication management within the interprofessional team, it's really assuring that we maximize the expertise and the contribution of each one of the members of the team. Doing that is by then doing this evaluation, but coming up with recommendations that could be implemented as part of the team, and that there's communication, that we document the medication therapy session we did, that we document our recommendations, and that we document the resolution of drug-related problems. And we do these by creating information exchange, by creating trust between the case management team, by creating communication, by creating referrals between each other. And that is really what is going to integrate comprehensive medication management and making it an effective tool as part of case management. So I wanted to share with you some process of care that we use when we conduct comprehensive medication management, and it's more to kind of highlight to you what are some of the steps, all right, as we approach a patient, as we're conducting these services or these sessions, what are some of the process? And we have in pharmacy what we call a pharmacist patient care process, and it's the approach. What is the approach that we use when we're conducting these services? What is the approach that we use when we're doing comprehensive medication management? And the first thing is we collect information. So collecting information from particularly the patients, the right patient interview, maybe sometimes family members. How are you taking the medications? What are you using? Are you having any issues with it? You know, really a comprehensive drug history for that patient, but also collecting information from other sources. In our case, from the electronic health record. In our case, for the patient discharge documents that we receive. Then assessing that information, really getting to the meat of it that I talked to you in the definition, is ensuring that each of the medication that patients are taking are appropriate, have an indication, you know, a medical indication or a indication for use that is used appropriately and that is not causing any harm to that patient. Then we need to develop a plan. How are we going to address those drug-related problems that we did? How are we going to address the issues that we see? Then we're going to implement those recommendations. Then we're going to come back and we're going to follow up and we're going to evaluate, did that intervention really make sense? Did it achieve the intended results that we had when we implemented that intervention? And this is a process that goes on and on. So, right? It's a cycle because, again, we come back, we collect information, we reassess, and it happens every time that we conduct these services. In our School of Pharmacy, we actually develop our own kind of what we call process of care. And we call it the P3 process of care because it's a program that we have that is really intended to provide these services in various contexts. And the major difference is that in here, we really added one step to collecting the data, which is engaging the patient. We really believe that the first step to do this is patient engagement, is a relationship with the patient, is all of those things that we know are important in providing a person-centered care. Then we're going to collect information. So the same thing, we're going to assess it. We're going to look at the different disease. We're going to look at the drug therapy. We're going to develop an action plan. We're going to implement that action plan. We're going to reevaluate and we start all over again. So again, there's similar processes and steps, just adding the engagement of the patient. So how is CMM and how we are currently integrating the services within the Maryland primary care model? So we know that now we have two choices that practice can have, is that right? If they do want to engage with a pharmacist to be able to provide the services. So the first one is getting the services as part of your CTO services, all right? So the CTO per se will have a pharmacist. Many of them have pharmacists that they either employ as part of the CTO professional, individuals, but also some of the CTOs may contract with an outside pharmacy, may contract with an outside pharmacist, and may contract for that pharmacy or pharmacist to provide the pharmacy services that are part of the menu of services that the CTO is providing. Other practices have chosen not to engage with the CTO and do all the components of the Maryland primary care program on their own. So what they have done is they either have hired a pharmacist that is part of their staff and is part of the practice, is part of their interprofessional team, and is the one that assists, in the case management providing the services. Or other practices have chosen to do direct contracting with either a pharmacy or a pharmacist for them to be able to provide the services. In both cases, the concept is that this is embedded in the practice, that is part of what you do, is part of that case management menu of services that you provide in the patients to achieve the goals of the model or the goals of the program. So one of the questions that I get asked a lot by some of my colleagues in the practices is, okay, who are the candidates? Who are the best candidates within a practice for us to be able to do this comprehensive medication management, particularly when we may not have the resources, particularly with many of you have so many patients that you're trying to provide the services and you are going to have to prioritize, all right? Particularly for some of your case management services, which of these patients will benefit the most? So I created a list here for you that is not all-inclusive and that doesn't exclude all patients in the practice having a need at a particular time to have these services, but really to give you a context of how you may want to prioritize to start really providing these services. The first one is a transition of care. And we know that this is a perfect time. When individuals have this transition of care, it's a perfect time to do, at a minimum, a med rec. at a minimum, do a medication reconciliation to make sure that there's consistency, that there's no inaccuracies, and that no issues between the medications that patients got at discharge with some of the ones that they have at home. How many of us have seen when we do a med rec that their patients taking two of the same thing, the same class of medicines, but at the hospital they gave one brand name or one particular agent, and at home they had another one. And nobody figured that is the same class of med, but nobody really looked at. So at a minimum, a med rec, but ideally a comprehensive medication management evaluation to assure again that these are the meds they're taking, there is consistency, they're appropriate, there's no drug-drug interaction, and all of the above. Also, patients with chronic diseases, and in a particular case, remember that our practices emphasize mostly diabetes and hypertension. So patients with diabetes, hypertension, patients with multiple chronic diseases are ideal candidates for this because many of them, as we know, have polypharmacy, and many of them we know are using multiple medications. Again, patients that may have health literacy issues, or patients that need more patient education, that may need more assistance to understand how to take their medications, why they're taking it, and how to really monitor the appropriate use. We also know patients that we may think that are non-adherent to treatment, patients that come in our practices and continuously are not following the recommendations. Those are patients that are great candidates to figure out what's going on. Why aren't you taking the medication? Are you taking it differently? Are you having difficulty accessing the medication? One of the major reasons that we see is that patients are not adherents because they can't pay for the med, they cannot afford the copays, or they have transportation issues, and they are not able to really go to the pharmacy to get the med. So we can develop services around that to really help the patients become adherent to that particular regimen. We also know that patients that have complex medications, some patients are using medications that we call narrow therapeutic index, which means that, again, the dosing is really critical, right? Things like warfarin, antipsychotics, insulin, opiates. Some of these require probably more hand-holding and more patient education to make sure there's not what we call drug misadventures. Also, patients starting in a new medication, this is a great time not only to assess the other meds they're taking, but also to provide appropriate education. And then patients that may have chronic disease or liver disease, again, mostly because we do know that we may need to do adjustments in the dosification. These are patients that may be at risk to having more adverse events of many of the medications. So we want to make sure that they're dosed appropriately, that we follow them, and definitely patients that are receiving dialysis, we do know that they do require very careful medication management assessment and follow-up. So I mentioned to you in the beginning that one of the things I wanted to do was really clarify the difference between a medication reconciliation and a comprehensive medication management. And the reason I'm doing this is because I feel that sometimes there's confusion in our practices. How do we classify what we do? A med rec, again, is a more episodic, maybe one time, it's an episodic event where we really create a list of all the medicines that patients are taking, and we compare those to either medications that patient had at home. If it is a hospital discharge, we make sure that there is consistency in the way that the prescriptions were written. Again, we compare the existing and the prior or previous medication regimens to assess if there's inconsistencies, if there's something that is missing, if the dose is correct, if the patient are actually taking, what are the patient actually taking? We don't go in the depth that we do in CMM, where we actually, in comprehensive medication management, remember what I described to you, the process? We really evaluate each medicines. We make sure that is the right dose. We make sure that we go into assessing drug-related problems. We make sure that we really do a very comprehensive assessment of the appropriateness of those medications, and then we come up with goals and we come up with interventions. So again, there is a difference. I also wanted to highlight that a med rec is not just asking the patient, what are you taking, and document it. It's really a step further, like it says in here. It's really corroborating, confirming that this is what the patient is doing and comparing, all right? Comparing existing and previous, comparing what's happening between the different lists that we have at our practice. Again, it needs to be done, with thought. It needs to be done, again, looking at those omissions, duplication, dosing errors, really looking at the regimen that the patient is using. So again, just want to encourage you, just asking the patients, having them fill out a form is, again, not what we call MedRec. So I wanted to then, so we talk about definitions, we talk about the steps. I wanted to then give you some examples of how some of these services have been integrated into the practices, and again, how you may approach integrating comprehensive medication management within your practice. And so the first one is, I have probably talked a lot about this, transitional care, all right? Is again, anytime there's a transitional care, I believe that it really requires two things. It requires a MedRec, but it also requires a comprehensive medication management session with that patient. And the reason is because, again, here's what we see the most need. We see the most need because there have been a change in the patient status. We see a need because there may be a change in regimen. We see a need because the condition may not be controlled. And we may need to assure that the medications, the dosing that the patient are taking are really appropriate, all right? We also know that here is where, again, that interprofessional team communication, collaboration, and referral is critical. So again, having a transitional care process where any patient that experience one automatically, right, gets referred for the CMM and a MedRec that is documented, that a plan is developed, and that there is follow-up, and that there's really continuity of care for those patients. We also have some practices where the way to do it is that we do what we call consults, right? We develop a consultation service where providers, case managers have the ability to identify some challenging patients that they have, some challenges in drug therapy, and then refer those patients for CMM or refer those patients for further assessment. So again, it is developing a mechanism where a case management team, a provider can actually, at any point, refer those patients that are in need of these services to another healthcare provider to do so. So that, again, is going to be something that is a way to do it, and is a way that we can, again, manage the needs of these patients. I wanted to also share that in some practices, what it has been developed, what is called a medication adherence program. And the way to do that is identifying those patients that have adherence issues, then referring them for evaluation. And I showed you here, this is just one tool. There's many tools that we can use to help our patients with medication adherence. But I wanted to share with you one of the programs that we had where, again, we work with some pharmacies where patients do receive the medications already in dosification forms, and also with these systems where they have all the medicines for the morning, for the afternoon. So it's easier for them in terms of keeping track and adhere to the medication. Again, there's other that are blister packs. There are many, many ways to do this, but I just wanted to show you that this, again, could be a way for us to assess some of the needs of our patients by developing these medication adherence programs. So all of these services that we provide are great, but we need to also make sure that as we develop in CMM, and we integrated as part of our practice that we also develop outcomes metrics, how we're going to evaluate that these services are really achieving the intended outcome that we're looking for. And I just listed here some examples for you that are part of what we do anyways, all right? It's part of what we do as part of the Maryland Primary Care Program is that we monitor and we report and we track many of these metrics. So definitely, disease control, we're tracking the control of our patients in terms of managing many of these conditions. We also do patient satisfaction and member engagement. And we do know, and there's data that really indicates that patients that receive these services are more satisfied and more engaged because they're part of the management of the condition. They understand the medications, they understand the regimens, they know what to do and when to seek care. So again, patient satisfaction goes up. We also know that if we can track what are those drug-related problems we're identifying and the resolution to make sure that, in fact, our interventions are working, and definitely measuring adherence to different services and adherence to meds in particular. So I share with you, and you have this also in your resources, but I wanted to share with you that, again, these measurements and this assessment of these services really results not only in clinical effectiveness and clinical outcomes, but it also results in economic savings and economic outcomes, not only for the employers, for the providers, but also for the patients themselves. So this was an article of a study that we did looking at the clinical effectiveness and cost savings, particularly in diabetes patients, when we provided these services. And what we demonstrated was that, again, not only did we see clinical improvements, but we also saw a return on investment. We also saw that in these patients that received these services, we were producing economic savings, not only reduction in hospitalizations and ED visits, but really an actual reduction in the cost of the therapy, not only to the employer, but in many patients, many cases to the patients and the health system in general. So I just wanted to use this just as evidence and to say to you that I'm not here talking to you and saying these services are effective because I'm a pharmacist, but we do have data that, in fact, these type of services do improve care and help the practices. The same thing is I wanted to share with you, again, some data of that we have done, particularly with our P3 program, integrated then in case management. We're able to demonstrate again that the patients that receive these services, their HEDIS standards are even above commercial plans nationwide, but also that even after you account for the cost of the service, we see an overall decrease in total cost of care. So what I wanted to do now was to, we talk about definitions, we did all of that. I wanted to really get us to a dialogue, and I wanted to use a case for us to go through the steps, that I go through how would you implement and how would you provide comprehensive medication management, and how do we identify drug-related problems, and how do we do recommendations. And again, the idea here is just to use it as a case study. Is not all-inclusive. I try to just do some highlights for us to have a dialogue. But again, it was just as a representation of what can we do and how do we provide these services as part of comprehensive medication management. So I'm going to read the case, and then I have some questions for you. And the way that we're going to do it is we're going to have you put it into the chat, what you will do. I don't know. I'm just asking the staff. In many cases, I don't know if maybe you could even speak. But the idea here is to make it interactive. So it's a 60-year-old patient who was recently discharged from the hospital due to an episode of pneumonia. The patient comes in, and the past medical history, he has COPD for 5 years. He again has diabetes type 2 for 3 years, hypertension, arthritis of the hand for 5 years. The medications are as follows. The patient is taking a Symbicort 1 to 2 puffs twice a day, metformin 500 milligrams twice a day, diazide once a day, omeprazole 20 milligrams a day, and Jardiance 10 milligrams a day. We know that the patient, again, lives alone, has no transportation, has limited income, and really a health plan is Medicaid. And when we ask about some of the prevention and prevention measures, he has not had any vaccinations in the past 5 years. So the patient is coming to your practice, and then the question is, let's apply what we learned. So based on what we talked about, that comprehensive medication management is and the criteria, what are the first steps in conducting comprehensive medication management in this patient? Okay. So Rachel says that number one, she will assure that the patient is attributed, is that right? And refer it to CTO for pharmacy and social services. Okay. Sabrina says that again, review the list of medications and how they're taken. Okay. So do a med rec, that right? That would be the first step. Ask for a medication, making sure that the patient has medication and he has no transportation. Shani, that's excellent, that right? So one of the things that we're going to do is, as we do the med rec and we go through the steps, is making sure the patient has the meds, actually physically has them and knows how to take it, okay? And so they keep coming, verify the medication list, actually, okay? So a med rec, but the patient is a home visit and make sure he has all his meds. Excellent. Review the problem list, med recs, and they work through evaluating, assessing each medication. Perfect, Tracy. So again, remember that when we were talking about the steps, the first thing is engaging the patient, is making sure that we have a conversation with that particular patient. It could be a visit to the clinic, or it could be like you all saying, telephonic intervention, a telehealth, where again, we start to conduct at a minimum a med rec. Med rec, remember, was creating that list, all right? Creating the list of what the patient was discharged from, what the patient had at home, and making sure what exactly are you taking or you're going to take. The other thing that we're going to do is gather information. So the information is not only for the patient, but what did we say? We're going to make sure that we get the records of the discharge. So we want to make sure that we figure out what happened during the admission, what was the meds that he was sent on, gather the data, and really making sure that we got the med history, looking, some of us may be able to even get the pharmacy data. So if they in fact got the meds, that right, when they were discharged from the hospital, then figure out what they're having. So really is making sure that we approach it with the med rec first, making sure we have that, then making sure the patient has the meds. That was excellent, is that right? So the patient may not have the medication at hand. So making sure that the patient physically has the medications, and then assessing each one of those. Remember what we defined, what are the medication for? Is it appropriate? How is it going? So excellent. And I will have time for questions at the end if there's something that is not clear. But definitely that is systematically and is really assessing each of the meds and assessing what the patient has at home. Don't forget that we talked about what OTCs, we need to talk about alternative medicines. All of that plays a role in our evaluation and assessment of what is going on. So let's assume we did all of that. Then we're going to do a drug-related problem. Is that right? We're going to assess the therapies, and we're going to see what are the drug-related problems that the patient has. So let's assume for discussion that the patient was taking exactly what you saw that I had in the patient case. So I don't know if I need to, let me go back. So it's, okay, here we are. So it's clear. So we know that the patient then is taking Symbicort, 1 to 2 puffs twice a day. He's on metformin, 500 milligrams twice a day, diazide, omeprazole, and Jardiance. So what do you see in here? What could be what we define drug-related problems? What do you see in this regimen that you may want to address? and that you may want to develop some recommendations on steps for. What do you see at a glance? Okay, so the Symbicort dosing, monitor blood sugars. The dosing is missing of diazide. The only thing is missing is there's only one single formulation of diazide. It already is a combined drug. Okay, so let's start with the Symbicort. Okay, so the first thing there is that we need to make sure, number one, that the patient knows how to use it. Is that right? The other thing is, what in the patient history may want you to make sure that the patient is actually able to use the Symbicort. That's right, the patient has arthritis. Thank you. So again, we need to make sure that the patient is able to manipulate. And some of these new inhalers, they're tricky. So we need to make sure the patient surely knows how to use it, but also that he doesn't have any type of limitations, right? Because he has arthritis in the hands. So that's one, they know how to use it, they use it appropriately, they use it all the time. Some of our patients tend to be rely, or they're used to doing more relief inhalers only when they need it, and it's important that the patient know that it's not when you need it. You need to use it consistently. Metformin. So what about metformin? Again, good drug for diabetes. But we all know that usually the 500 twice a day is not the therapeutic dose, right? A lot of our patients do need the 1,000. So again, he's also using Jardiance. So does he need both? What is the diabetes control? We need to take a look. Exactly. We need to know the A1C. We need to know what is the level of control. Does he need both? Is it a matter of helping him to modify his diet so he will only need one of the drugs? So again, assessing what is the diabetes control and are these the appropriate drugs for these particular patients? In this particular case, he has Medicaid, so there, we need to make sure that number one is in the formulary, but number two, the copays may not be an issue. But in other patients of ours, Jardiance could be the copay, could be significant, particularly some of our Medicare patients. So maybe looking at that if it wasn't a Medicaid case. The other thing here is Jardiance and diazide. We do know that, well, patients may be able to use both. Diazide is a diuretic. So again, making sure that we monitor, right? Particularly in a patient that may have limited income, maybe the diet is not the best, the nutrition, so making sure that we monitor the diuretic. But we also know that Jardiance and a diuretic together could cause dehydration. So again, that may be a drug-drug interaction where we may want to think about, do we give him something else for his hypertension and not use the diuretic? So again, it may be not the best drug-drug combination. Maybe we can stop one or do the other. So again, we see maybe what we call in drug-related problem, maybe the dose of the metformin is not appropriate. Maybe he could only need one, is that right? Disease control, the Jardiance and diazide, the ability of him to use the inhaler, patient education to make sure he's using it correctly. And maybe there's another thing in here. What about omeprazole? Again, it may be that I don't see any indication for omeprazole. So again, it could be that this is a drug that was given to them just because in the hospital they gave it and they continue with it. So again, we see the social issues, and we see again the need for vaccinations. A patient with COPD should require vaccinations. So again, I just wanted to use this as a quick highlight. I think I am slightly over time. So I don't know if we have time for questions. You do have resources. And again, I encourage you to take a look at that. Any question, please feel free to contact me. And again, I'm turning it over to the staff. I don't know if we have time for questions. If not, you could put the questions in the chat, and I'd be more than happy to answer them at a later time.
Amazing. Thank you so much, Magali, for your session here today. Fortunately, we are at time, but folks can drop their questions in the chat, as she's mentioned. we will send those over to Magali. She'll answer them and we can go ahead and post those on the website. So you'll have access to her answered
Happy
questions.
to do that.
Thank you so much.
Again.